Okay, it looks like we've got a pretty full house joining already, so maybe we'll just dive into it, and anyone late can join us. So welcome and good evening for those recently joined. Again, my name is Matt. We appreciate you taking your time out of your evening to join us for this educational session. Again, photobiomodulation is relatively new to wound care in Australia, and so we hope this introduction to its context in chronic wound care is valuable to you all. Tonight's event is brought to you by Woundcare. Those of you that know and those of you that don't, Woundcare is an Australian-owned and operated distributor of medical devices across the entire continuum, from inpatient through to rehabilitation. Woundcare is the supplier of the EmoLED device that delivers the phototherapy that will be introduced by most of our speakers tonight. So if you need any support queries outside of the event, commercial or scientific or otherwise, feel free to reach out to Woundcare. I'd like to begin by acknowledging the traditional custodians of the land in which we gather, wherever that may be around Australia today, and pay my respects to their elders past, present and emerging, to extend that respect to Aboriginal and Torres Strait Islander peoples here today. I'd also like to acknowledge the traditional owners of the land in which you are on today. So first of our speakers tonight is Chris, who is the Regional Director of APAC for EmoLED. He's based in Singapore, and he works directly with the inventors of this technology, whom are based in Italy. Chris brings a decade of experience working in and around Australia with medical devices and wound care technologies. This world is nothing new to him, and he brings a lot to the table to help us gain momentum. Chris will attempt to summarize the key scientific and mechanistic concepts that underpin photobiomodulation with blue light. Some of it's reasonably content heavy. I trust you'll appreciate the vast majority of it. He will also share some preliminary details of the first multi-center prospective trial that was run assessing photobiomodulation therapy with blue light in non-healing wounds. You'll hear this referred to probably by multiple speakers as the BLUR study, which is short for blue light ulcer reduction study, but we'll get more on that later. Chris is unable to be with us tonight, and to avoid the technical difficulties, we've actually pre-recorded his session, which we will start very shortly. If you have any questions relating to Chris's presentation, I will be more than happy to field those in the Q&A section at the end. Otherwise, enjoy.
Good evening. Thank you very much for joining our webinar tonight about EmoLED, photobiomodulation with blue light LED, a new treatment modality in modern wound care. Before obviously going into the product itself, I'd like to make one step back and would like to give you a little bit of a background of the theory behind tonight's topic. And essentially it starts with phototherapy, which we also call light therapy, which is essentially the interaction between light and living organisms, and particularly in our interest, of course, the therapeutic interactions. And as you know, we have, as humans have for many, many years since ancient times, utilized sunlight for various therapeutic interactions. Most commonly known, I think, is the vitamin D synthesis with regards to interaction between UV light and the skin. But of course, there's many more areas where light plays a key role. And of course, with the advent of artificial light, coming, for example, from lasers or light-emitting diodes, LEDs in this case in particular, the medical applications of light have seen major developments because it is now possible to study and to utilize the interactions between specific wavelengths and the biological systems such as human tissue. But not all light forms are the same. For example, the visible light you see on the right side of my slide, spanning essentially the UV and then the real visible light and infrared light portion of the electromagnetic spectrum is made up of various wavelengths characterized by specific energies and frequencies that produce different biological effects on living organisms. And I will allude to that a little bit later. On the upper part of that slide, you see that obviously very different wavelengths have also very different effects on, in this case, it's our skin, on the different layers of skin and the penetration into it. And We will see that later as well. When we talk about phototherapy, we have three different types of phototherapy that we can classify into. We have one that works on what we call the non-thermal arena, and we have a thermal one. So the non-thermal one we call photochemical, which is everything below 45 degrees. But we do also have a thermal one, which is upwards of 45 degrees. That leads to apoptosis of cells. When we talk about EmoLED in this case, we are on the left side with photobiomodulation therapy, which is based on the concept of endogenous light absorbers, which we also call chromophores, which inhibit or stimulate a biological response and in its nature are never destructive. When you look at some of the others, such as the photodynamic therapy, also under the non-thermal phototherapy, it is a therapy that uses exogenous chromophores, so added from the outside, and that is usually a destructive biological response. But today the focus is on photobiomodulation, and please keep that in mind. It's never a destructive process that is behind that. Now, what is photobiomodulation in a closer definition? Actually, there's a relatively new terminology that was just only defined in 2014 by the North American Association for Laser Therapy and by the World Association for Laser Therapy. What photobiomodulation is, a phototherapy, as I mentioned, that utilizes non-ionized forms of light sources, including lasers, LEDs, but also broadband light in the visible as well as the infrared spectrum. Photobiomodulation is a process which involves endogenous, as I already mentioned, so endogenous light-absorbing molecules, which is essentially light absorbers within the tissues or within the organism itself. And we call them chromophores, and they absorb the light, whatever waveform that is, and transform light into energy to trigger and modulate specific physical, which we call photophysical, as well as chemical events, which we call photochemical events or effects at various biological scales. And the interactions between the light and those chromophores have demonstrated to modulate biological processes, including, and that is particular in terms of wound healing relevant inflammation, angiogenesis, but also triggering a cell signaling pathway that essentially recruits transcription factors, which in return activate several genes involved in multiple aspects of cell biology. Now, how does EmoLED fit into that? EmoLED is a medical device that is based on the theory and concept of photobiomodulation. So it utilizes visible light with a wavelength within the blue light spectrum. And I will explain later why blue light is so important. But we are with EmoLED only within 400 to 430 nanometers on that wavelength spectrum. And its mechanism of action can be explained by the absorption of that blue light by certain electron transport chain molecules and flavoproteins. And as a result, we know that the therapeutic outcome of photobiomodulation with EmoLED has 3 levels of action. Number 1 on cell metabolism, number 2 on the inflammation, and number 3 on fibroblasts, and I will explain that later. The therapeutic outcomes are quite substantial. Number 1, alleviation of pain. Number 2, alleviation, or as we also call it, resolution of inflammation. And essentially really the induction of wound healing, particularly in chronic wounds that have been stalled for, we know it, months, years. And last but not least, it also helps with the promotion of faster and better wound healing and tissue regeneration. Now, what is the mechanism of action with EmoLED blue light? And I tried to summarize it. I could certainly talk for much longer, but I have only 20 minutes. So essentially, if you look at the irradiation with EmoLED blue light, as I mentioned, we are on the blue light spectrum between 400 to 430 nanometers. You can see on the right side the light wave spectrum and where the blue light is and where EmoLED fits into that spectrum. And you can also see that one of the key light absorbing molecules, the protoporphyrin 9, is at its highest absorption level in that specific blue light range that EmoLED has. It absorbs light in all other ranges, but it has its peak in the blue light that EmoLED is placed in. In order to achieve the resolution of inflammation, as well as faster and better tissue regeneration, we have three key actions. Number one, EmoLED acts on the inflammatory process. So essentially, no matter it is a chronic wound or an acute wound, it is addressing the inflammation. And it does so by attracting the flavins, which are light absorbers that are also in the tissue. And once the flavins have been attracted by blue light, they stimulate the production of reactive oxygen species, ROS, which are signal transducers of cellular pathways involved in tissue repair. Once the production of ROS has started, it triggers certain key cascades of events. Number one, that is primarily relevant, of course, in chronic wounds that have been stuck. It kicks the wound back, so to speak, in an acute stage, because it is in a transitionary phase, pushing the wound back into a production of pro-inflammatory agents such as TNF alpha, IL-6, or IL-8, and that in return triggers an anti-inflammatory response, also initiating the transition of the pro-inflammatory phenotype of the macrophages M1 into an anti-inflammatory phenotype M2. And last but not least, it also releases pro-angiogenic factors such as the VEGF or eNOS. And that all helps with addressing the inflammation, and it helps the wound to get out of the inflammatory stage and the resolution of the inflammation. The second point it acts on is cell metabolism. As we know, cell metabolism is a key factor in wound healing, particularly when we talk about ATP. A lot of chronic wounds, of course, are deprived of ATP. And what happens with blue light essentially is that in presence of protoporphyrin 9 within the cytochrome C or cytochrome C oxidase, blue light is essentially contributing to enhancing the cellular respiratory process through the activation of certain molecules, such as cytokines, nitrogen monoxide, or growth factors. And that all contributes to production of ATP and essentially the fuel of cells, so to speak. And it helps with the cell metabolism and helps to initiate all sorts of other processes once this is happening. And last but not least, it also has an action of fibroblast. Fibroblast, as we know, the key cell in the reconstruction or within the extracellular matrix. In this case, this is not a light absorber, of course, but nevertheless, blue light also modulates fibroblast metabolic activity. And on top of that, it inhibits fibroblasts when they're pathologically altered, such as myofibroblast, for example. And as a result of that, we see a faster and a better restoration of the dermal architecture, which essentially is a better collagen synthesis, a faster collagen synthesis, as well as a better distribution across the wound bed of the collagen fibers, and also, of course, in a more orderly way. And that is also driven by the downregulation of the myofibroblast activity, which essentially is leading to less scarring as an outcome of that. Now, I'd like to introduce you to the device itself and to the treatment itself. I have to mention upfront that, of course, EmoLED is not a therapy in itself. It is a adjuvant therapy that should always be used in addition to your standard of care, whatever that standard of care may be. But it is not a standalone treatment. So you still need your, for example, compression bandage when you have a venous leg ulcer, or your absorbent wound dressing if you have exudates. So you need definitely make sure that you don't use EmoLED in isolation. But having said that, EmoLED is very, very versatile in its application and its indication, essentially, because we have no limitations when it comes to lesions. So we say EmoLED can be used on any type of lesion that you may come across, be it chronic wounds such as, of course, venous leg ulcers or any type of leg ulcers, be it diabetic foot ulcers, pressure injuries, vasculitis, but also a more acute type of lesion, such as in burns or skin grafts, particularly when skin grafts are about to fail. So when we see the skin grafting, starting to fail, EmoLED is a huge salvage for that. But it can also be used in post-operative wounds, particularly when we talk about in context of scarring, and in this case, keloid scarring, for example. The only contraindication that we currently have with EmoLED is neoplastic lesions, and that's not really a contraindication as such, but as per regulators, we have to put it down as a contraindication because we don't yet have any proven indication, so to speak. We haven't done any clinical trials on substantiating the claim that we would be able to use it in neoplastic lesions. But we know that light and blue light in specific is used oftentimes in cancer treatments as well. So, but I don't want to advocate here at this point. Now, the treatment as such is very safe as well as easy to use treatment. Number one, it is not utilizing any harmful wavelength. Blue light is not harmful. As a matter of fact, you may sit right now in front of your phone or your laptop and it's emitting blue light. Of course, over long, we know it's not a very healthy interaction, but in context of the treatment, it's absolutely harmless, and it's specifically not using any UV light and no harmful radiation. It's very handy and portable. You can see it on the right side. It's just about a bit smaller than an iPad. It's a bit thicker than an iPad, of course, but it's very, very lightweight. It comes with a battery that is very long lasting. It comes with an extra charger, of course, as well. It usually is very, very well tolerated by patients. They feel a little bit of a warmth, which of course is also sometimes very comfortable for patients because they feel something is going on. But it's certainly not hot, so it's soothing, so to speak. And as of now, we don't have any side effects ever reported or any adverse events ever reported. One word about EmoLED. We talked about blue light and that it triggers all these cascade of events. But one thing I have to mention is, the power of the treatment of the therapy is not just depending on one variable. There are multiple variables that are playing in concert, so to speak. It's not just the blue light in the range of 400 to 430 nanometers. Now, it is also the light dose. So it's also depending on how long do you apply the light, how far away is the light emitting diode from the tissue. In this case, in EmoLED's case, it should always be between around 4 centimeters plus minus 1 centimeters, between 3 to 5. So that's the distance it should always be. And of course, then the time exposure being either 60 seconds or 120 seconds, depending on the type of wound or etiology they're using it on. And of course, the number of repetitions per week could be once a week, could be twice a week. Last but not least, I'd like to give you, before we later on go into the real life evidences from our two guest speakers tonight, I'd like to give you just a brief overview over the existing clinical evidences and the up and coming clinical evidences that EmoLED has embarked on. So you see quite a busy slide. EmoLED has been very, very active in the recent 3 years. I have to say that the treatment itself is still a relatively young treatment. Only about 4 to 5 years old since it was first launched, but it has a lot of clinical credentials to it. One key study, which was the pivotal study, which I will be introducing in a minute, is the BLUR study that has been done, I think, in around 2018 timeframe, and was published on 18-19 and was published last year in a big journal. But there's been numerous other studies on various indications, be it in burns, be it on the fibroblast activity related to keloid, be it in diabetic foot ulcers, or in some other relatively important types of wounds, such as pressure injuries. Forward-looking, and that's something very, very exciting. We see that there is the Hermes study, which is a single-center prospective randomized controlled study being done in Italy by Professor Alberto Biagesi, and it's on neuroischemic foot ulcers, essentially, which is a very, very exciting study because not just because it is a randomized controlled study, but it is on diabetic foot ulcers, which we know is a huge problem almost everywhere in the world, but particularly in the Asia-Pacific region. And I'm looking very much forward to that study being finalized. It is ongoing at this stage, and I hope in the near future we would also see that being published. I mentioned before that the pivotal study was the BLUR study, so blue light for ulcer reduction study. And it was a very, very interesting study. First time that this concept of blue light was experimented, so to speak, in real life on patients. We had 90 patients, out of which 84 completed the study. We looked at various types of wounds, but predominantly, or the majority of the wounds were venous-like ulcers, but we had arterial ulcers, mixed ulcers in there as well as some surgical lesions. And obviously the outcome, or let's say the idea was to look into various aspects, particularly looking at the 10 weeks, because that's the magic number in wound healing that will give you a good idea once or if the wound is on a good trajectory to healing. So the primary endpoints of that first study were looking at the 10th week mark and looking at the percentage of wound size reduction in conjunction between EmoLED plus standard of care versus just standard of care. And some secondary endpoints were, of course, the safety of the treatment, as well as the pain reduction and the healing trends at week 10. As I already mentioned, it was published in 2021, and the outcome of the study essentially reads that the treatment with EmoLED, in addition to standard of care, enhances the rehabilitation of chronic wounds with a statistically significant difference compared to the treatment with standard of care alone. And this result in particular is evident in venous leg ulcers. Just a couple of words on the treatment protocol, and which is very interesting because usually you have different patients, of course, that you enroll in a study, and of course, different comorbidities could potentially lead to different outcomes. But we took that, or EmoLED took that out of the picture because each patient became his or her control. Essentially, we looked at two different types of wounds. Number one, if a patient had 2 lesions that were smaller than 5 centimeters in diameter, then we took one as treatment and one as control. Or if a patient had a lesion with an axis longer than 5 centimeters but only one, then we split the wound into 2 pieces, so to speak, and one was treated and the other one was the control. The protocol itself was, as I mentioned before, most of the time we use 60 seconds. In particular, in this case, it was in the early days where 60 seconds was standard. So EmoLED 60 seconds plus standard of care versus standard of care alone. On the right side, you see a little bit of a graph that shows the constitution of wounds that were enrolled in the study, the age. And I think what I have to mention here is the average age of the wounds that were enrolled in the study was 67 months. So it wasn't necessarily a very easy study where we just took wounds that were relatively fresh. No, 67 months obviously are wounds that have been around for a very, very long time, obviously have not been healing in so many months and years. And you see this result in a second, but this is something I have to mention. So we're looking at a very, very significant average age of the wounds that were enrolled in the study. And the outcomes for the primary endpoints was essentially, as already mentioned before, EmoLED and standard of care was significantly and statistically significantly performing better than standard of care alone. For example, in the EmoLED and standard of care group, we reached around 58% average wound surface reduction within the 10 weeks for all types of wounds that were enrolled, but 67% for specifically venous leg ulcers that were enrolled versus 37% only when it comes to all wounds and 40% respectively for the venous leg ulcers. So you see whether it's all wounds and specifically for venous leg ulcers, we had a much better performance than with EmoLED and standard of care versus standard of care alone. Regarding the secondary endpoints, where we wanted to prove the tendency of healing as well as the pain and the safety. So number one, there were 5 serious adverse events and 1 adverse event, but all of these events were not related to the treatment itself. They were all related to the patient's comorbidities. But we could also show the pain reduction, and primarily showing on the BAS scale that after week 4, we had a tremendous reduction kicking in when it comes to pain, which, to be honest, was expected, because we also know that inflammation and essentially the pressure on nerve endings certainly creates pain. And if we reduce the inflammation, so will we also reduce the pain. It's not as simplistic, but there is a correlation, of course, as well. And we saw also from a trend that the rehabilitation was much, much faster in the EmoLED plus standard of care group. Last but not least, some of the cases and the progression in those 10 weeks, as you can see here, between the treated and non-treated wounds, in this case, an 86-year-old patient with, in this case, of course, still a relatively new wound. And you can see on the upper part, the area that was treated, on the lower part, the area that was non-treated, and the performance after 10 weeks. And similar here, an 82-year-old patient, in this case, a 99-month-old ulcer. And you can see that on the area where we treated with EmoLED, the reduction was almost, again, complete, and the wound was essentially healed after 11 weeks or at 11-week point of 10 treatments. And when you look at the non-treated area, obviously you can see the wound was still quite open and not healed at all. In that sense, I thank you very much for joining us tonight, for listening. I'm very excited, of course, to hand over back to Matt, and then introduce, of course, the speakers that will present the real-life cases that they have been doing on behalf of EmoLED and in their clinics. And I wish you a very, very good evening. Goodbye.
Thank you very much to Chris virtually, and if he is tuned in, I hope he enjoyed listening to his own presentation. That was a very content-heavy summary of what is a lot of research going on in the background. And so if any of the audience would like copies of the in vitro or the in vivo studies relating to the information that Chris presented, please reach out to us. We'd be more than happy to provide it to you. Now, following from the research that Chris has presented, I would like to now introduce Dr. Harry joining us from Malaysia. Dr. Harry is with us live. However, this is a recorded version of his presentation for saving on the technical difficulties, but he will most certainly be here for the question and answer session. Dr. Harry is extremely well renowned in the space. He's the president of the Malaysian Society of Wound Care Professionals, the chair of the Commonwealth Wound Alliance, and the president-elect for the World Union of Wound Healing Societies. This is all on top of a busy schedule that's underpinned with a regular clinical load as the head of the wound care unit in Kuala Lumpur Hospital in Malaysia, where Dr. Harry has been undertaking some of the first investigations into photobiomodulation with blue light outside of Europe. I'd like to welcome Dr. Harry now as he shares some of his experiences, some of the investigations they've been undertaking into how this technology is offering them new possibilities for patients with non-healing wounds and the outcomes attributed to that. Again, for the sake of technical issues, this is a recording. Dr. Harry is here with us, and any questions you have for him can be saved for the Q&A. We hope you enjoy.
A very good evening to everyone. It's a pleasure to be invited to actually talk about new photobiomodulation therapy for chronic wounds. My name's Dr. Hari from Kuala Lumpur Hospital, from the Wound Care Unit, Department of Internal Medicine, Kuala Lumpur. Interestingly, basically, when you look at wound management, there's many types of modalities that we can actually use. Now, if you look at this, basically, there's a lot of advances, basically bicellular stem cells, compression, therapy devices, all that. But I will just focus on photobiomodulation. That is actually a very important topic, and it's coming up. And most people are looking at different types of LED light, I mean, before this itself, people will say a ray of sunshine is very helpful for patients to help in their problems and also to heal different conditions and all that. And you also get vitamin D from it. But the problem is too much of it also is not so good because you end up with what you call this cancers and all that. Now, in this particular case, I would like to actually present about photobiomodulation and show the cases that we have actually done, the case series that we undertook in Kuala Lumpur Hospital, which is the largest hospital in Southeast Asia with about 2,500 over beds. If you look at the publications, there's various publications on using blue light photobiomodulation. I think before this, they have already presented on the blur trial looking at blue light for ulcer reduction. And then they've also done what they call this photobiomodulation in terms of how it actually helps in human fibroblasts and keratinocytes, which is very, very important for wound healing. And also in terms of looking at human keloid-derived fibroblasts. And we did a case series report which we published on the effects of photobiomodulation with blue light on diabetic foot ulcers. Now, this was actually published in the Wounds Asia journal. And you got quite a number of other studies, basically looking at neuroischemic patients and also for burns and non-healing ulcers in diabetic patients, right? So quite a lot of studies are there. And as usual, when we start off first, we talk about evidence-based medicine, as alluded to by David Sackett's, and then we move to evidence-based practice. And in our position, especially as clinicians, we talk about real-world evidence. Now, when you look at diabetic foot ulcers, basically, now these ulcers can actually be stuck at the inflammatory stage. Now, Westermin 85 mentioned about hemostasis and tissue repair, and inflammation is a condition where you find that it's stuck. And there's a lot of papers basically coming out on hard to heal wounds, non-healing wounds, stagnated wounds. Even EUMA, the European Wound Management Association, has come out with that and has launched that. And there are a lot of people actually looking at chronic wound disorders and all that. So it is important we look at normal wound healing and diabetic wound healing itself. And we actually looked at what we call this, looking at diabetic foot cases. Now, the reason because in Malaysia, basically, diabetes is quite a major problem. There is at least about 20% of the population who are diabetic above the age of 18, and about 25% are diabetic above the age of 30. This was published recently in 2020. And then we actually looked at what we call this diabetic subjects, where we actually put on the EmoLED blue light shine about 2 minutes each week. So every week when the patient comes to us, we basically put the blue light. This is actually the EmoLED device, and this is the blue light here. So you need to wear your goggles, basically protection for yourself and also for your patient itself. Now, in this particular patient, basically what we call this, you can see it's a diabetic foot ulcer, first treatment, male, 86 years old, who had an ulcer for about 6 months. So he had a DFU over the left foot with a transmetatarsal amputation. There was no infection or inflammation, but it is like what Terry Swanson would have mentioned. Basically, the granulation tissue is not very effective. And I mean, this is not a good quality granulation tissue. So there's a little bit of stuffy areas and all that. So, it could be what they call this early infection, basically, or even if you look at the International Wound Infection Institute Wound Continuum, which was launched basically again in the year 2020, this year, we talk about basically contamination, colonization, and they talk about local infection, spreading infection, and also systemic infection. So here you can basically say with contamination or that we have to remove. So we actually used a honey-based product. The size was about 10.1 cm by 2.2 cm. So what happened is EmoLED basically was used in this particular case as an adjunct. So 120 in each area. Okay, there was about 2 areas. You can see we applied the light basically on the particular wound itself. Right? And by second treatment, you can see the improvement. Nice and great, superb regulation, DC regulation. And by the fourth treatment, basically, and by seventh treatment, it is completely closed. All right. So it's important basically when you look at that at the last treatment here, the wound is completely healed. Okay. So this was actually how we and within what we call this the 8 weeks, you can see the wound is closed. Now, what you need is within 4 weeks, you need at least 50% reduction in the wound size. But within 8 weeks, we have already closed the wound. It's supposed to close in 12 weeks. Now, there's another patient who is a 76-year-old male who presented with a 2-week diabetic foot ulcer over the right foot. He had a second raised amputation of the second toe. All right. And you can see basically a lot of maceration over the area, and the size was 8.5 by 2.9 cm. And we use honey-based dressing to actually slough and also remove what we call this all the dead flash tissue. So when you put EmoLED on, basically, you find, when you apply, basically, the difference is after the fourth treatment, nice red granulation tissue, And by last treatment, you can see the wound is bleeding much better. Okay, this is 10th treatment. 10 weeks. This is another patient, 60-year-old male who came with a diabetic foot ulcer, about 5 months old, with a DFU over the right toes. All right, you can see granulation tissue there. We're trying to actually speed up the whole thing, a bit of maceration. Primary testing was honey-based products basically, and the size was 5.5 by 2.5 cm. So by what you call this, shining the light there basically, by 4th treatment and by the 6th treatment, and finally last treatment, the wound completely closed. Right. So this actually what we call this a good thing to show that by these 8 treatment, 8 weeks basically, the wound is closed. So very good in terms of closure rates. The 75-year-old male gentleman with 9 months DFU over the right toes also came in with 1.6 by 1.3 cm in length and width, and we actually use a collagen dressing. It took a bit long time for this, but however with the blue light basically with EmoLED, by the 10th treatment, the wound was completely closed. Okay, so these are all stagnated wounds and all that. So basically, in all 5 diabetic foot patients which we actually recruited with various chronicities, we showed very good improved results, and 4 of the wound completely closed basically at the end of the study. And the last wound has improved tremendously, undermining has completely granulated, which will continue to improve with proper care. All right, and this is a study that we actually published. Basically, publications are important, so that's important to look at. Now, can photobiomodulation help in all chronic wound healing? All right, and you find here in this case, basically, if there's a lot of inflammation with increased matrix metalloproteinases and reduction in the TIMPs and all that, a lot of tissue can basically be destroyed, especially extracellular matrix. So when you find what you call this, these chronic wounds are actually trapped in the inflammatory stage of the wound healing itself. So this is actually published in JAMA basically, and looking at the frequency of debridements and time to heal by Randy Wilcox. So one of the things that we looked at is basically your photobiomodulation will kickstart healing. That means that empirically for chronic wounds. So whether to shine or not to shine is very important. Now we actually came out with the next trial, which is a BLESS trial, the blue light empirical shine study. Right now, this pilot study is using blue light therapy to overcome wound chronicity. So what we're going to do is we're going to kickstart healing. All right, there's a lot of products nowadays basically which help in terms of kickstart healing basically, because these wounds are all stagnated wounds, hard to heal wounds, or non-healing wounds. Right. So you find that some definitions show that patients who have been actually managed by a proper wound team within 2 to 4 weeks, if the wound is not closing, it's actually a non-healing wound. At the same time, you find now chronic wounds are also getting defined as hard to heal wounds because they need to have a lot of what we call this other factors which needs to be managed. Now, if you look at the blue light empirical shine study, the BLESS pilot study, the current investigation focus on using EmoLED empirically to resolve commonly seen small wounds inflammation and to kickstart a chronic wound to heal. So basically, what we call this is control at 1 weekly exposure for 4 consecutive weeks continuously to kickstart healing. That's what we did for this particular group. So we had 7 patients with set of care and wound preparation to healing after 4 times of EmoLED adjunct treatment. So basically, if you look at this is an 82-year-old female with a chronic venous ulcer over right leg. Wound duration was about 4 months. So when we actually start to what we call is use the EmoLED, it starts to heal. But don't forget, standard of care is very important. Compression must be there. All right. So with compression and proper what we call is blue light, you can see the wound already healing well. It's starting to kickstart. All right. It helps in kickstarting the healing itself. There's another patient, 57-year-old female with chronic venous ulcer on the left foot. Okay. No medical illnesses. Wound duration is about 3 years and 11 months. And you can see here, it starts to improve. All right. Within what we call is about 2 weeks plus, the wound will start to heal already basically. So it's much better. It's improving. Same thing with another 65-year-old female with a chronic venous ulcer on the right leg. Wound duration is about 1 year, 5 months. And you can see by what we call this 2 weeks, the improvement in the wound size and also epithelialization and stuff. Here's another patient, a 53-year-old male. Now this patient has got hypertension and diabetes and has got non-healing wound. The wound duration is about 3 months basically. But you can see what we call this, it starts to improve. So all of these wounds basically were managed for 2 weeks to see how, with the blue light itself, to see the improvement itself. And you can see the wound getting better. All right. So that's important. And the thing is, if you can see the first few cases were basically venous ulcerations, which actually have got lots of other pathology, fiber scuffing. They've also got problem with the increase in the girth and all that. So you need to make sure you have got proper standard of care. Now, when you look at diabetic foot ulcers, one of the main things is after your assessment and then cleansing, debridement, and the dressings, you actually, what you call this, make sure before the dressing itself, you apply, after cleansing and debridement, you apply your EmoLED, your blue light. And then you, what you call this, you put your dressings on and you put, what you call this, proper offloading techniques are actually important for these patients. This is a patient who has got hypertension and diabetes with a non-healing ulcer with the right torso. The wound duration was about 2 years, 5 months. But you can see here, within 2 weeks, it starts to kickstart healing. The wound size is becoming lesser. And the thing is, the wound is looking much better, right? There's improvement there. There's another patient, basically, who's got a chronic venous ulcer, 73-year-old female with the right foot. There's no known medical illness, just has been, what you call this, in the sedentary lifestyle, standing most of the time, basically. And the duration is about 1 year, 4 months. And you can see here, within 2 weeks, there is a improvement in the wound milieu itself. The wound bed, you can see lots of what you call that epithelialization in this patient. So this is actually a good case to show that you can use the blue light not only to close the wounds, but also to kickstart healing. Because one of the things that we look at, basically, if you look at health economics, there might be the problem with pricing, with the consumables, basically, with the reimbursement, basically. So one of the things that you can do is by applying over 4 times, you actually start to kickstart healing and the wound starts to heal. The new trajectory is actually formed for wound healing itself. And in this particular patient, a 65-year-old male, diabetic foot ulcer over the left foot, wound duration was about 3 months. And you can see here, basically, there's so much of improvement within 2 weeks, all right, especially in this particular wound here. Now, this is important when you look at the BLESS study itself. So, stall wound showed progressive improvement of the wound bed and reduction in size. So, one of the most important is area assessment was done with length and width, and there was reduction in the wound size itself. Epithelialization and granulation were noticed when you look at wound bed preparation. I know Gary Sibyl in the year 2000 basically talked about what you call a wound bed preparation. And after that, we've got so many ways of assessment with the time concept, timers, time CDST, and then even your moist and all the other ways of assessment and triangular wound assessment. And at the end of the day, you can see basically these 12 wounds are actually moving into the healing phase of trajectory. The increase in the epithelialization of the at the wound edge further supports these findings. So you find that you're using EmoLED blue light, photobiomodulation, LED blue lights, basically 400 to 430 nanometers, adjunct therapy once a week over conventional therapy helps as an adjunct therapy in addition to standard of care to help kickstart healing in hard to heal central wounds. So therefore, you basically continue with the standard of care and you add on basically what you call this the adjunct therapy. So this is something what you call is very important. It's an added modality. That means in terms of looking at wounds, basically, and basically don't just manage the hole in the patient, but the whole patient. That means look at the comorbid conditions, manage all of those, and then manage the local wound itself, and add on basically the blue light. And that actually helps as an adjunctive factor to speed up wound healing itself. Now, I know a lot of you are now talking about wound hygiene, basically looking about cleansing, looking at about dressing, and trying to actually cut down what they call this infection, removing biofilm. Now, do all of that basically. And then on top of that, you add what they call is a blue light. Now, one of the good things about the blue light is basically it increases your fibroblasts. So it doesn't have to be shining over only on that area, and it actually have an effect on the fibroblasts, where you actually have fibroblast proliferation and all these things. It can actually, what they call is, cover a larger area. Because areas surrounding the place where you actually shine the light will be able to get more fibroblasts in. And this actually helps basically to cut down inflammation and help to push it into the proliferative phase. Okay. And if you can see basically even in the South Sydney Vascular Center's trial success with treating chronic leg wounds, they've also looked at this. All right. So some of the things is basically is important, and it's good to look at basically when you're having this kind of cases. Now, when you have chronic wounds and all that, it's important to what you call that have different types of modalities to help you with that. So with that, thank you very much.
Thank you very much to Dr. Harry for what was the recorded session, but I know that he's here in the background listening and ready to take your questions at the end. I think it's clear to say some interesting and very eye-opening experience from our friends and colleagues in Asia, which makes a perfect segue into Hayley. Hayley Ryan sharing her experience from Australia. So last, but by no means least, many of you will already know Hayley, and for those of you that don't, Hayley is the chair of our Wounds Australia peak body here nationally. She's the director of our own wound consultancy business, and she's supported by a wealth of clinical experience in complex wound management. Hayley has been pioneering the use of this photobiomodulation therapy with blue light here in Australia since it became available only recently, with some rather encouraging results, of which I'll let her share with you herself. As a local speaker, unfortunately, Hayley will be joining us live, and she'll be able to answer your questions immediately after in the Q&A. So please take it away, Hayley.
Thank you so much for that lovely introduction. I am actually going to be presenting to you live this evening, so I will take the screen. Here we go. Wonderful. Okay, so one of my interests happens to be around new technologies, and the EmoLED certainly does that. Today I want to talk about new therapy options, obviously using the photobiomodulation with the blue light case studies. I'd like to say a big thank you to RiaCare for the invitation to be here this evening. A very short disclaimer, you will be seeing some wound pictures, and as Dr. Hari's just done, I'll be presenting some of the cases that I've worked with patients. I have permission to tell their stories and share their photos with you. So what I would like to just briefly talk about is non-healing wounds, why the EmoLED device, and then talk through a couple of my case studies. I think it really does start here. I think that it is fair to say that wounds, and in particular chronic wounds, they're a global concern. And if I talk about just Australia on its own, we're looking at 400,000 people at any one time are dealing with a wound. It costs our economy around $3 billion per year, which is 2% of the health expenditure. So we have a major issue on our hands, and I would go a step further and say that chronic wounds are really a silent epidemic. So what is a chronic wound? And I'm sure you're all aware that this is one that fails to progress through the phases of healing. And Dr. Hari said it very politely and went through how they often will get stuck in that inflammation phase. And this is one of the issues we face with aiming to heal a wound. In fact, non-healing wounds represent a failure to achieve complete reepithelialization in the appropriate temporal sequence of tissue repair. As you can see by the red dots on the screen, often wounds that are not healing are characterized by that excessive inflammation, including elevated levels of proteases, ROS, and inflammation cytokines. By senescent cell populations with impaired proliferative and secretory capacities, so we have real issues that are getting hindered when trying to heal. If you have a look at what will actually pull us out of that, what will aim to heal is in the green, which is looking at excessive inflammation, which leads to degradation of newly synthesized growth factors and ECM. So what I'm saying to you is there's a real need to restore that proper balance of the cytokines, the growth factors, the proteases, to really recruit that functional cell. So I'm talking about the epithelial cells, the fibroblasts, and the endothelial cells to the wound area. If we achieve that, we will remove the person or the wound from that inflammation phase into that healing capacity, and that's what we all want. So sometimes we start to look at other devices. What technologies will help us with those chronic wounds that we know are stuck in that inflammation phase, and some of our patients living with a wound for a very, very long time? I don't want to go into the literature too much because my colleagues before me have done that so well, but there is real evidence coming out about the blue light on superficial wounds, and it's capable of inducing that homeostasis by means of the photothermocoagulation process. So it is certainly worthwhile having a look at. And Chris went through some of this earlier, and this graph shows the study that was done on the mice models to examine the inflammation phase of wound repair on superficial wounds. And what you can see is the treated and untreated wounds and control values are shown in red, green, and blue, respectively, and represent the cellular densities. Overall, a fast healing process was confirmed. Chris went through this study earlier, and this was the study done by Fracalavieri et al., and they showed I really liked how they were actually able to get each wound and half the wound to be the control and then treated the other half of the wound. And they were able to show the comparative changes to reepithelialization. And you can see that on the screen. You can see that those that were treated had an 80% mean gap in the reduction of the lesions. And you can see that the treated also healed. So why the EmoLED? Well, when you come to patients who are living with chronic wounds and you have tried all means and you've looked at them holistically, as Dr. Hari said, sometimes we have to try other strategies. So I'm going to take you through now a couple of short case studies to demonstrate my experience in Australia using the EmoLED device. And I'm going to kick off with Mr. A, who has a post-surgical wound. Now, Dr. Hari touched on all of the mnemonics that you can use, and you will all use different ones, and that's okay. But I use the HIDE systematic approach to assessment, which is history, looking at their history, examining the person and their wound, doing further investigations if needed, diagnosing the wound, and then implementing your treatment plan. So in this case, this patient was a 52-year-old, a non-compliant diabetic. And what I mean by that is they would often eat incorrectly, which would flag their higher levels of their sugar. They did have an amputation, so at the transmetatarsal, and they identified as being Aboriginal. They had multiple hospital admissions for wound infection. In fact, this patient bounced from the home environment that they lived in and had the wounds treated back into the acute care sector in the hospital several times. On examination, they had a dehisced wound after the amputation, and there was lots of purulent exudate. There was some odor as well. The further investigations that we did do was a swab, and given the fact that there was non-compliance with the diabetic diet, we did do a HbA1c. The overall diagnosis was a right foot with a dehisced wound, and multiple dressings were trialled without success. So then what we did was we continued with the same op-site post-op dressing, and the only implementation or change that we did was to utilize the EmoLED device. So as you can see on the top of the screen, that is the dehisced wound on the 15th of September. We were using post-surgical dressings, and there was a known infection. By the 9th of October 2021, the treatment remained the same, but the wound became stagnant. And I think you would all agree, looking at this wound, there was some callus building up, which would have hindered that. And we continued with the EmoLED device. On the 1st of November, we're starting to get real traction. We've removed that external callus by sharp debridement, and you can start to see the wound really taking effect. By the 10th of November, we're left with this small superficial area of the wound, and I'm happy to report that the wound actually healed by the 14th of November, which was only 1 month and 4 days of a very complex patient who also had the confounding issue of diabetes. There were certainly challenges along the way. There was reluctance for the patient to allow staff time to actually attend the wounds. In fact, this was a patient who would only allow you to do the dressing if you could actually say it would be done within 5 minutes. We've all had those patients. You've got to be quick. So that was quite difficult to manage. But what did help us is that because the EmoLED was only 90 seconds once a week with basic treatment and dressings thereafter, this actually helped us because it wasn't a difficult treatment and the patient accepted it. So it was a good success. On to my second patient, we're going to look at Mrs. B and her venous ulcer, again using the HIDE systemized approach to assessment. This was a 71-year-old lady who was overweight, was a smoker, certainly had a poor diet, but this wound was actually 3 years in the making. She had had it for 3 years that we were aware of. The person again lived in an aged care home, so a long-term care facility, and had multiple infections as well. There was copious amounts of exudate, lots of malodor. There was some edema, but the pulses were okay. We did a swab and we certainly did a Doppler toe pressures as well. And we concluded it was a right anterior and lateral lower leg venous ulcer. The dressings remained the same, including the compression, because as Dr. Hari said earlier, compression is pivotal to healing any venous insufficiency. So the only change we did again was to use the EmoLED device. And given the ongoing infections, we continued with the silver dressings. So this was the wound on the 1st of September, again using the silver dressings and compression. The wound remained the same for some, according to the patient, it was looking the same for the last year, and over 3 years just continued to get bigger, and we commenced that EmoLED device. On the 5th of October, there is a notable reduction in size. You can see that it's certainly gotten smaller. However, we were seeing signs of some rolled edges, and it did become stagnant. The exudate remained, although was not as copious as originally noted. There was some edema, and we had to focus on, as we always do, not just the wound bed, but looking at the external limb, which had that hyperkeratosis. By the 25th of October, we had actually healed the entire anterior part of the actual wound. The lateral area remained. The exudate had certainly decreased, and we were starting to see some great signs of epithelialization. The edema, however, remained even with the actual compression that was being used. However, I will say that the compression was only a light or a class 1 compression because the patient found it too uncomfortable to go higher. So it's sometimes that catch-22 because edema can be problematic to healing the wound. And I will also say, because the wound actually was smaller in size, the odor was under control, the patient began to walk again and visit shops and socialize. And so there was a lot more walking, which could have also included the increase in edema. By the 4th of November, we see a huge reduction. By the 25th of November, we have some small areas remaining. And by the 2nd of December, the wounds were completely healed. And this took 3 months, but for a wound that has been in the making for 3 years, that was really an ideal outcome for this patient. So the challenges in this case were certainly exudate management. And the interesting thing with the EmoLED is that this patient had significant issues with ongoing infections. Since commencing the EmoLED, we didn't have any more concerns. So it was, again, a great outcome. So where to now? So what I would say is, let's think about, this is a new product. It's a new technology. So how can we look at technologies to support things that are quite difficult, other complex etiologies like pyoderma gangrenosum? Our EB patients, that you have to be very careful of what dressings you're applying to their wounds because the slightest friction can create another one. And we heard from Chris to note that, neoplastic wounds are contraindicated, but what about fungating wounds? This is about managing the symptoms of odor, pain, and exudate. So would EmoLED be a potential in those cases? Possibly. My take-home message for you all today is to always use the evidence-based practice information and apply it to your patients. And you've heard a lot tonight, and so that will be very helpful in your practice. Prep the wound for success by implementing not only this into your practice, but setting up that wound bed for the way it needs to go to get out of that inflammation phase. Evaluate the outcomes for the benefit of the patient with difficult to heal wounds. And I guess my final take-home message is I'm going to give a quick plug for Wounds Australia. If you do want to learn more, we have our wonderful conference coming up in September from the 14th to the 17th. You're lucky tonight because I've actually seen one of the co-chairs of the scientific committee online. They've done an exceptional job, and I know that they would welcome everybody to attend. So we do hope to see you there. And with that, I'd like to thank you very much for your time. Back to you, Matt.
I'd like to thank you all for joining us this evening. It's been an absolute pleasure hosting both yourself, Hayley, yourself, Dr. Hari, and Chris by virtual extension.